Welcome to the Reframing Eye Care Podcast. I am your host, Dr. Maria Sampoulos. Today's guest is Dr. Beth Yackey. Welcome to the podcast.
Thank you. Thank you for having me. It's a pleasure.
Well, it's great to have you on. I mean, you're an amazing woman optometrist doing amazing things in the industry, and I'd love to highlight women like you so other women can kind of look up and see what the opportunities are for them in the industry. And the fact that you work in a retina clinic was pretty unique for me when I found out. So for those of you that do not know Mary Beth, she joined Cincinnati Eye Institute in 2004, and she provides patient care for 3 of their locations and is a provider of optometric services and a member of the vitreoretinal team. And she has an emphasis on diabetes, flashes, floaters, macular. She also recruits patients for various research projects and is involved in teaching and educating optometry and ophthalmology residents and fellows, and has been a past member active of AOA and a lot of other philanthropy committees and things like that in the industry. So welcome to the podcast.
Thank you. Thank you for having me again.
Yeah. So it's pretty impressive resume there. How did you choose optometry?
Okay, so this is a long story. I'll try to keep it short, but my cousin was 2 years old when his mother noticed that his pupil was white. I was in 4th grade. And in 4th grade, I thought, okay, interesting. They took him to the emergency room. Of course, a white pupil to a 4th grader doesn't mean much. But when they started to discuss options with the parents, it was basically, we've got to enucleate this eye immediately. He had gone to several ophthalmologists. I grew up in a really small town and ended up at the Cleveland Clinic. They took his eye almost immediately, assuming that a 2-year-old boy has retinoblastoma. Back in the 80s, there wasn't as many, we weren't very good at pathology. We're always improving. One of my things is once you think you know something, you know how stupid you are because there's something around the corner that's better. And you're always going to have to continue to learn. But they did remove his eye. They gave the parents about 15 minutes to decide if they wanted to remove the other eye, thinking that the cancer would spread. The parents said, no, we're just going to take our baby home with one eye. But when they did the research and sent the eye to labs to actually do the path reports, they found it was not cancer. So when I was in 4th grade, I was kind of frustrated for my cousin. My cousin is not nearly as frustrated as I am. I will be honest to tell you, one thing I've learned of this is that when you lose an eye as a child, it's very different because you adapt well and you learn how to, live life as is. Not that that's not the perfect life, but so then I decided I wanted to invent an eye for him. So I'm still working on that. But that's really what brought me into this field and this career path.
That's great. Have you always, when you practice optometry, did you want to do retina as a subspecialty in ophthalmology group? Because we don't really hear optometrists being in a retina clinic.
So no, and again, God works in weird ways. So I started my practice in 2004, graduated from the New England College of Optometry, thinking that I wanted to do primary care. I went into private practice for 3 years alongside with LASIK. I was doing refractive surgery at Cincinnati Eye Institute. So about 3 days of refractive surgery and then 3 days in the private practice office. And this was right after 9/11, so things were a little bit difficult to have people pay for, elective procedures and such. And I really didn't love selling selling things. I didn't like selling glasses. I didn't like selling the art of LASIK and all that stuff. So what I really found was my passion for retina. And so one of the retina physicians, so at the practice I work with, we have about 56 ophthalmologists. And so there's all different subspecialties. And when the retina physicians noticed that I was seeing things that he wasn't sure I would be able to catch in the periphery, and he kind of tapped on my window and said, hey, why don't you come work in retina? And the rest is kind of history. So yeah, there's my passion. And I work now in retina for full-time, 5 days a week for the past, I think we're going on 20 years or something. So yeah.
Great. What's your role as the optometrist there?
Yeah, so it's a really unique role. So as Dr. Maria said, we as optometrists in retina are kind of rare. I can say that there's probably 3 or 4 of us in the country, and I hope this number builds. But basically what I do is I get to look at the patients, triage patients for the retina specialist, decide whether those flashes and floaters need to move on to retina surgery, With the geographic atrophy drugs, I'm their hands and eyes basically for getting referrals in, looking at the GA patient, deciding whether or not it truly is from age-related macular degeneration, or whether or not they need treatment, or if this is something that we have to, we want to make sure it's not growing. Just with the evolution, for example, of the new GA drugs, that brings in just in Cincinnati 300 patients per day who might need treatment. That's a lot of people. So, they need more than just the retina specialists to be flooded with these. So doing the triage work for that. Also, I act as a liaison to the optometric community. I'm very blessed. My friends around the area colleagues all around can send me images. We discuss whether or not they need to see the retina specialist. I'm kind of like their direct connection to our retina specialist, and basically triage, help them decide if this patient needs help, or sometimes just a second opinion over the phone. And then finally, I love to educate the community. I do a lot of continuing education programs for our colleagues. And so, trying to get the word out of how to communicate best, but play a lot of different roles, but I love it because I do hope that my colleagues feel very, confident and less intimidated in talking to me versus maybe a retina specialist that can kind of connect and bridge that gap.
No, that definitely, it's very impressive if there's only 4 optometrists in the country, and you being a female, like trailblazer in our industry, doing that, right? That's great. And then, yeah, you're right. It's easier for me to say, talk to you about something, and if I'm uncomfortable about something, then talking to a retina specialist per se. So that's good that you're able to bridge that gap in that area. Because I know sometimes I'll be nervous about something and I'll send it out to a retina specialist. What's some common referral errors that you see from optometrists?
I think because flashes and floaters is such a common call, at 4:00 on a Friday, a lot of us dismiss how important those signs and symptoms can be. So one of the things that I see is that optometry is really good at catching tears and breaks. But remember that just because you don't see a tear or break on the first day, there's number one, there could be other things happening in the eye. So think about, all the other things like ocular migraine, anything that moves or changes the retina can cause a flash, including like a melanoma in the eye, like in the retina. So there's so many things that can cause that, down to dehydration, systemic conditions, high blood pressure, low blood pressure, kind of the list goes on and on. So if the patient calls, trust me, nobody wants to come to the doctor. They're not calling to have like a conversation. And if you don't find a break or tear, remember to see them again. And, 4 weeks is probably appropriate. Reevaluate. Also, the patient is nervous and scared when there's new floaters. So make sure that you can educate them to say, hey, gosh, I don't see anything here. And if you're really uncomfortable and you think the patient really needs to be referred, refer the patient. But I think the number one thing that optometrist does is they say, oh, it's just a PVD. You're going to get used to this posterior vitreous detachment. We all go through this, ignore it. And then, that's why I think sometimes the retina detachments and tears get missed, not because they were maybe even there on the first visit. If the flashes are still happening, we know there's probably still traction on the retina. Follow up and make sure that traction is released. I always like to see my patients through the PVD process until their flashes stop to make sure that there is no tear or break.
So you recommend 1 month after the initial dilation visit, but if they notice, of course, more signs, then sooner, correct?
Absolutely. Yes, absolutely. Thank you for pointing that out. Yes.
Yeah, great. So there's a lot of patients that have macular degeneration and then are referred for treatment. What can optometrists do for that and help the patient with their journey?
So this is huge. Believe it or not, I'm not proud of this, but I am one of the largest XDEMVY writers. Lids and lashes, it makes absolutely no sense that a retina person should be doing that. And the reason is because the population of patients who have the need for treatment for AMD have horrible blepharitis. And so when their lids are inflamed and they have horrible condition on the ocular surface, and then the retina specialists in my office are putting betadine in their eye once a month at a minimum, probably, think about how horrible that would be if it were you. My scribe recently went through an Avastin injection for something else. And I will tell you that I never realized how horrible it is the second day. So, and the reason that she had such an inflammation and irritation is because of the chemicals we use. But if you compound that with blepharitis and they already have a dry ocular surface, I mean, so as an optometrist, if you're referring in a patient, we want these folks to be able to get the best vision possible. And through treatments, we can try to preserve that. But it requires a team effort of taking care of the whole eye. So please look at the lids, lashes, dry eye, anything that you can do to help control those conditions will help the patient have a better outcome.
Now, what about like just referring, manage themselves optometrists and refer for retina in the practice?
Yeah, so central serous choroidopathy is something that I think we all can handle as optometrists. I can't remember the last time I actually referred one for a laser, and lasers are kind of, less and less common in the retina space. We still have one of the few photodynamic therapy PDT machines around, and that's usually what we would use to treat something like CSR, but they don't even make that machine anymore, if that tells you how much we don't treat with that. So what I would say is look for CSR. CSR is something that you can ultimately monitor. If you have questions, because I know that can mimic other conditions, always refer. I'm not saying don't refer. I'm just saying, and talk to the patient, because often the fluid can go away if we figure out what the trigger is. And the trigger is just a reminder, ask the patient if they're getting enough sleep. Stress, we all have stress. We know that can happen to any of us at any time. Isn't life just about the ups and downs? But also look and see if they're on any medications that might cause their psyche to kind of alter. I've seen it in many bipolar patients, and just communicating to the doctors, their primary care physician, having that conversation. Again, this is medical career that we're in is very much about teamwork, not just with retina specialists, but with all sorts of subspecialists, including their primary care physician. One of the things we found was too much caffeine. So they might say they sleep enough, but if they're drinking, Monsters, Red Bulls, we were starting to see a CSR in teenagers because of the intake in caffeine. And obviously that drives stress, that drives cortisol release, that drives not sleeping. All of it kind of compounds. Also ask if they've had, the number one thing I will say is a nasal spray. If they're on a nasal spray with a steroid, so many times we forget that those contain steroids, and so many people are addicted to nasal sprays. So if you can just ask them to stop that, hopefully the fluid would get better, or ask them for a different medication without the steroid in it. Injections throughout their body. But those are the main things that I see that I feel like trigger this. And if we can get rid of that response, then you look like a hero, because you end up helping to resolve the fluid and hopefully minimize the scarring.
Yeah, thank you so much. A lot of us have OCTs now. It's becoming the standard of care. What are some, clinical pros in managing patients with OCT testing? Because, a lot of doctors are like, oh, there's a change, refer. So
I think the big thing, there's so many things that you can see on the OCT, and there's so much that we're still learning. And even though it's an older technology now compared to 20 years ago when I started, we didn't have this. So 20 plus years anymore. So anyway, so the one thing I wanted to point out, just to dovetail on the CSR case, the central serous retinopathy, a lot of people are concerned that it might be a choroidal neovascular membrane, and it can be, so you have to look at that carefully. But when you look at an OCT, especially with something like central serous choroidopathy, look at the thickness of the choroid. It will be thicker in people who have central serous choroidopathy than the average patient, versus something like age-related macular degeneration that has a CNVM, where the choroid can be it can be thinner. Other things about looking at the OCT for central serous is you kind of want to know, is this their first event? You can look for other patches of atrophy from the retina and the other eye even. I think there's so many pearls about OCT that it's hard to kind of limit it to just one. But my main take home, just to dovetail on the fact that I think we should be, as optometrists, monitoring central serous, is look for those, shaggy photoreceptors that tell you that this isn't just happened yesterday. So if the photoreceptors look kind of like a moth-eaten appearance at the edges, it's been chronic. And then other signs of atrophy throughout the retina.
Yeah. What about retinal artery occlusion? What are some best courses of action? Because I don't see a lot of that, but when I see it, I panic.
Yeah. It's one of those things that I think needs to be sent to the emergency room immediately. One of the big pitfalls that all of us as eye care providers, including ophthalmology, general ophthalmologists, do. I mean, we all tend to want to send them back to the primary care physician. But to be quite honest, at least here in Cincinnati, since I've been practicing, that is not the way that we do it, because until the primary care physician actually gets to the patient, gets them into the office, then talks to the cardiologist who needs to do the heart scans and the carotid Doppler and the MRI, it's 3 months. So that's too long. So if you think you're doing your patient a job by getting them into their primary care physician, on average, it takes about 3 months and the patient could be dead. We want immediate care. Now, I hate to clog the emergency rooms because we know that sometimes it's hard to find the source of those plaques. But specifically, if you see a plaque and this is an acute finding and they have a cherry red spot, or even if it's a branch retinal vein occlusion, transient ischemic ocular attack, so TIA, anything like that, my advice is get them to the emergency room, make sure they're getting the workup that should be done. Ask about GCA, ask about giant cell symptoms. Do they have pain when they chew? Because that will drive a whole different workup for you at the hospital. And I always send them with a letter to the hospital. I do talk to the primary care physician, but after I've sent them, I don't waste time. So it's a timing thing. We want to make sure we get them right to the hospital. If they have the signs and symptoms of GCA, then we're looking for something else like, is this, ESR high, so we're sending them for lab work such as CBC, ESR. You might have to have a CRP done. We also want to talk to the rheumatology team versus the stroke team. And maybe there's both that need to be evaluated. But definitely, again, thinking about MRI, carotid scan, cardiovascular workup, and GCA. And we just want to get them right to the emergency room.
Yeah, thank you. There's a lot of new things that have come out recently. What does optometry need to know in the retina space for the new things?
So being that it is the month of March, earlier this month, March 6th, we are so excited because there's a new first ever possible treatment for patients who have macular telangiectasia. So March 6th is only a few days ago. We were lucky enough to be one of the study sites at Cincinnati Institute, so I have a little bit of information on this drug that maybe we're going to learn. Just like I feel like optometry has been really lucky to have a lot of good education on biomarkers in the OCT for geographic atrophy. I think we're going to have the same thing with MacTel, because MacTel is something that is easily misdiagnosed, probably underdiagnosed. Currently, we think in the population, there might be about 0.1% of the folks who have actual MacTel. But, we're going to be looking for definitely this to refer in. So on March 6th, this new drug is called Incelto. And there's a longer name that I'm really not good at saying, so I'm just going to call it Incelto for now. And basically, it's an allogenic, basically encapsulated cell-based gene therapy. So this means that this has to be placed into the retina. It is actually a surgical implant. And this, again, is for MacTel type 2. So let's just review what that is real quick. MacTel type 2 is basically a bilateral condition. This is where the macular capillary network and neurosensory atrophy occur. We can see things on biomicroscopic exam, including crystalline deposits in the retina. The vessels are ectatic. There's blunted venules. We're also looking for foveal atrophy in the more advanced cases or longstanding cases. I think the easier thing to look for personally is on OCT. There's this very classic draping appearance when you do an OCT where there might be some inner segment, outer segment junction kind of border irregularities, but the draping is it almost looks like a mesh of tissue over top of an area of hyporeflectivity, almost like it looks like a cyst in the fovea. That is MacTel. And so basically, we do want to refer those in for treatment. What this medication will do is slowly be released through this basically vial, and the medication over time will help to prevent, what they're saying is it slows the progression of the macular telangiectasia damage. So hopefully keeping atrophy from happening, which means hopefully giving these folks more of a chance to have vision or better acuity longer. So it's exciting just because we've never had anything like this. I'm sure there's going to be education on this being sent to all of us as primary care optometrists and everybody. I mean, we all need it. So because we've ignored this so much, and just like with geographic atrophy, we thought that there was only a smaller percentage, I think, of patients than we're realizing there really is. And so once we figure out how to diagnose and treat better, now that we have treatment option, we'll probably find that there's more than just 0.1% of the population.
Yeah, of course. Yeah. This has been such a educational podcast with you on it. It's great to see all the things that you've done in your career, and then you keep giving back with residents and to the profession. When you look back over your career, would you think that where you are today and what would you have told yourself starting out?
Well, I think a lot of the reason that we don't have very many ODs or in retina personally is just because we're afraid. We're afraid of what we don't know. Our education is amazing. Like I can't tell you how many times I have to explain to my colleagues in the ophthalmology department, basically what our training is like. And just that we have 4 years of learning the eye. We will never I don't plan on doing surgery, but we will never understand surgery the way that surgeons do. We will not ever understand the anatomy of an eye the same way because we don't dissect the eye multiple times, through the week. We do it in school and then we kind of move on. So what we are really good at is seeing things, but then understanding what goes behind what we're seeing sometimes is scary. So when I first started out, again, how did I end up in the retina group? I would find a tear in the periphery and go, what is this? Is it a lesion? Is it a tear? Is it a break? We have better technology now to help us get out in the periphery, and with the wide field imaging and, things like that to help us. But I guess my thought is what I would tell myself is in the beginning, again, I started in the anterior segment department. I started in primary care. If you feel like you have an interest in another part of the eye, don't be afraid to go after it. And Maria said this earlier, a female in retina is a little unique. Until this past year, I was, again, in my department only, one female. We had 11 retina physicians who were men, and we had, retina fellows who were mostly men. We hired 2 females this year. And I'm not saying it's a female thing. It's also a career thing, optometry versus ophthalmology. There's, again, almost 15 of them. And there's one of me and 2 part-time male optometrists who work like a half a day a week or 2 a day a week in the clinic. So, and this is my passion. So don't be afraid of who you are, what you look like, what your career is. I mean, within your guidelines of your training, make sure you're pushing those limits, ask questions when you're not sure, look harder. And again, don't be afraid to reach out to who you are referring to, be friends with them. They're going to work with you to help make your patients better.
If someone wanted to contact you, do you have an email address that they can contact you?
Yes. My simple email address is Dr. So Dr. Mary Beth Yackey. And my last name is spelled funny, but it is on the screen, Yackey @gmail.com. Yes.
Well, thank you so much for coming on the podcast, giving some clinical pearls and sharing your story. And thank you what you've done for our profession as well.
Thank you. Oh, thank you for having me. And look at you, Dr. Maria. You're awesome. So thank you.
Thank you.
Yeah.